Okay, so today we will discuss melanocytic lesions. This can be quite challenging topic, to be honest, because there is a lot of subtypes of both benign nevi and melanomas, and quite a lot of subtypes, especially those that are less common. They can very easily mimic the opposite. So there are several subtypes of benign nevi that can very easily mimic melanomas, and also some less common subtypes of melanomas can be very easily mistaken for benign lesions. So this topic can be really challenging, especially on the postgraduate level of pathology. So this can be very tricky for us, for pathologists. And very often the clinical setting is let's say at least important, not even necessary, because as a rule of thumb, it's good to keep in mind that if you have some lesion in old patient, especially in sun-exposed areas, it's good to be careful. It's good to be careful, and it's good to carefully examine the lesion, even if it looks bland at the first glance. Because in sun-exposed areas, in older patients, it's always good to keep in mind that it can be a melanoma. And again, in opposite, if you have something that looks worrisome under the microscope, if something looks worrisome in microscopy, and it is a small child or young adult, it's good to pause a little bit and step back and not to diagnose everything as a melanoma, because there can be a lot of benign nevi, and some of them are typical for young age, that can look really worrisome and that can be very easily mistaken for melanoma. So it's good to keep in mind, and as I said, the clinical setting is very important here. But we are on undergraduate level of pathology. What we do here in this channel is that we focus mainly on pre-graduate students. So we won't discuss everything, we won't discuss all the subtypes, because it would take us many hours. But we will touch the most common types of nevi and the most common subtypes of melanomas. So I think you will realize that this is not so complicated as it could seem at the first glance. So we will start with the most simple ones, which is the lentigo simplex, and then we will move to benign nevi, and we will finish with melanomas. So the first case we have here is a lentigo simplex. What it is? So here you can see the skin excision. There is an epidermis and dermis, and something happens in the middle of the excision. Lentigo simplex, it's a lesion that can be found especially in sun-exposed areas of the skin. So usually you can find it in the head and neck region, on shoulders, for example, or upper back. And what defines lentigo simplex is this. Well, it's definitely not the only histopathological change that you can appreciate. There are some additional changes that we will describe in a minute. But the, let's say, main change that defines lentigo simplex is this. Here you can see numerous melanocytes that proliferate, but they proliferate in a single layer. So there is a linear proliferation of melanocytes. So first of all, how melanocyte looks like. If the melanocyte is situated in epidermis, it's pale. So all those pale cells with a pale, almost empty looking cytoplasm, those are melanocytes. And also you can see that there is some sort of hyperpigmentation of the surrounding keratinocytes, especially in the basal layer of epidermis. So these are hyperpigmented keratinocytes, but those pale cells, those are melanocytes. And you can see they are quite numerous. They are definitely more numerous compared to the periphery of the excision. So this is the normal skin. This is not the lesion, and you can see that there is a one here, one here. So they are not exactly numerous. But if we move to the center of the excision, to the lesion, here you can see that there is a linear proliferation of melanocytes. But those melanocytes show no atypia. There are no atypia, there is no increased mitotic activity, so this lesion is completely benign. Also, what is a characteristic for lentigo simplex is that the proliferation is linear, as I mentioned. That differs lentigo simplex from benign nevi, because benign nevi, which we will describe in a minute, they are considered neoplasias, they are benign neoplasias, and in case of benign nevi, the melanocytes grow in, let's say, 3D structures, so they form clusters, balls, nests, and so on. So they form 3D structures, but in case of lentigo simplex, the proliferation is linear. That's also a thing that differs lentigo simplex from simple freckle. So simple freckle or aphelis in Latin, that is not, there is no linear proliferation of melanocytes. Yeah, they can be a little bit more numerous as well, but there is no linear proliferation. But in case of freckle, there is just a hyperpigmentation of the basal layer of keratinocytes. So in case of freckle, it's just a hyperpigmentation. But lentigo simplex, there is a proliferation of melanocytes. But as I said, it is just linear. So if you will see this line of pale cells on the border between epidermis and dermis, that's how lentigo simplex looks like. But as I said, this is not the only change that we can appreciate here. So usually there is some degree of hyperpigmentation of the surrounding keratinocytes. That's the first thing. And also quite often you can see some degree of hyperplasia, acanthosis of the epidermis. It is not so striking here, but very often you can see it as well. And here you can see there is some incontinentation of the pigment, so those are not melanocytes, those are just macrophages that swallowed the melanin. So those are pigmented macrophages, those are melanophages, those are not melanocytes. And as I said, it's very often you can see it in sun-exposed areas, which means that very common. It is not so apparent here. I believe we will see it in the next slides, but very often you can see the sun associated or sun exposure associated changes in dermis as well. Very often there is so-called elastosis of dermis, which means that there is a degeneration of elastic fibers in dermis as a consequence of long-term UV exposure. As I said, we will appreciate it in the next slides. Quite commonly there is a chronic inflammation as well. Maybe here we can see a few lymphocytes and plasmacytes around the blood vessels, but nothing striking. So quite commonly there is some degree of chronic inflammation and some degree of elastosis as a sun exposure associated changes as well. So those changes often accompany the lentigo simplex. So this is lentigo simplex, and as I said, it's absolutely common. It's an absolutely benign lesion, and it's a linear proliferation of melanocytes that differs lentigo simplex from nevi, and that differs lentigo simplex from simple freckle. The last thing I should mention is that you should be very careful with the diagnosis of lentigo simplex in older patients in sun-exposed areas. As I said, in this clinical setting, it's always it's always a good idea to be careful. And the main differential diagnosis here is lentigo maligna. Lentigo maligna, that is a lesion that we will discuss in the next minutes. And lentigo maligna, it's basically a melanoma in situ. So it looks similar, but you can appreciate some degree of atypia and let's say some histological signs of aggressivity of those melanocytes, which we will describe in a minute. So especially in older patients, it's good to keep in mind that the lentigo maligna, which is basically a melanoma in situ, can look very similar to lentigo simplex. So this definitely comes into differential diagnosis. Okay, so now let's move to nevi. So melanocytic nevi or pigmented nevi, these are considered to be true neoplasias in contrast to lentigo simplex. So these are benign neoplasias. They are very common. And as I mentioned before, in case of nevi, you can see a proliferation of melanocytes that form 3D structures. So they grow in clusters and balls and nests. So it is not just a single line of melanocytes as we could see in Lentigo simplex, but this is a 3D structure. There is many subtypes of nevi. Some of them are very common, some of them are more rare. We will discuss the most common ones. Very often the nevi start to form very early, even in the first year of our life. And then they grow very slowly in the course of many years. And they usually start in a junctional zone, which means on the border of epidermis and epidermis. So in this junctional zone, the nevi start to develop. And if you see nevoid structures, if you see melanocytes, clusters of melanocytes, only in this junctional zone, such nevus is called junctional nevus. And then as time passes, the melanocytes start to proliferate also in dermis. So you will see that the tumor has two components. One component is dermal, and second component is in the junction. And such nevus is called mixed nevus or combined nevus. And then as time passes, the tumor loses the junctional component, and you can see melanocytes only in dermis. And such nevus is called intradermal nevus. Those intradermal nevi, very often they are verrucose, so they form let's say small bulk or small tumor. So very often they are verrucose, and very often they lose the pigment. So macroscopically, grossly, dermatoscopically, they are not pigmented anymore, and they can be mistaken for some other lesion. But all of them are completely benign. And how they look like? So first of all, in this lesion, or in this example, in this slide, we have example of junctional nevus. So you can see that there is a proliferation of melanocytes in the junctional zone between the basal layer of keratinocytes and epidermis. And what are the main features that helps us to differentiate benign nevus from melanoma? So first of all, there are no atypia. So the melanocytes look quite bland, there is no increased mitotic activity, so there are no cytological atypia that could be worrisome. That's the first thing. Second, the lesion is symmetric. So when we look at the lower magnification, we can see that the lesion is symmetric, the maximum is in the middle, and at the periphery the lesion diminishes. So here you can see a smaller proliferation of melanocytes, and then we will go to the center, so the lesion is symmetric. Also, what we don't see here, and what we could see in case of melanoma, is something we call pagetoid spread. Pagetoid spread means that the single individual melanocytes start to grow and start to infiltrate the dermis, and they reach the upper portion of the dermis. So you will see numerous dispersed melanocytes not only in the basal portions of the epidermis, but you can see individual cells growing up to the upper portions of the epidermis. This is called pagetoid spread, and if you see this, you should be worried, because this is quite typical for melanoma, and it is not a typical feature of benign nevi. So be careful with this pagetoid spread, it can help. And last but not least, you won't see it here, but we will see it in a bigger nevi, or in the cases of, especially in intradermal nevi, because when you look to the lower portions, to the deeper portions of the nevus, the melanocytes will look slightly different compared to the melanocytes that are in the superficial portion of the nevus. We will discuss it in a minute in the greater details, so now just the brief introduction. This transformation of the melanocytes that looks different in the deeper portions of the nevus compared to the upper portions. This is something we call neuroid transformation or maturation of the nevus. And this is typical feature for benign nevi, and you won't see it in melanomas. And as I said, we will describe it in greater details in the next slides. So these are the main characteristics that help you to differentiate benign nevus from melanoma. And as I said, in this picture we have a junctional nevus, because you can see islands of melanocytes in the junctional zone between the epidermis and dermis. If you have a combination of both, we will call it compound nevus. So here you can see again, this is the lesion, and here you can see that the majority of the lesion is intradermal. But there is also a junctional component of the nevus. Here is a nest of the melanocytes in the junction. But here you can see that there is a majority of the nevi in the dermis. So this should be the compound nevus. But yes, the majority of the tumor is intradermal. And also what you can see here is it's not a good image, but I think we can appreciate it anyway. You can see that if the nevi are situated, or so if the melanocytes are situated in dermis, they look slightly different from those intraepidermal melanocytes, because those intraepidermal melanocytes, they are quite pale looking with a pale cytoplasm, but those intradermal ones, they are more eosinophilic. So they have a, let's say, brightly eosinophilic cytoplasm, and they are oval. So the nuclei are oval, the cells are oval, and the cytoplasm is more eosinophilic compared to those intraepidermal ones. But again, you can see that the cells don't harbor any cytological atypia, they are quite bland, and there is no increased mitotic activity. So this is still completely benign. Quite commonly, it can grow along the adnexal structures. So you can see the hair follicle with some sebaceous gland, and there are melanocytes around. And last but not least, this is the intradermal nevus. As I mentioned before, very often they are verrucose, so you can see that the lesion is not a flat, but it forms a bulk. That's the first thing. And second, you can see that the lesions is situated just in dermis. So epidermis is intact, but the whole lesion is situated in dermis. So this is intradermal nevus. And again, if you look at the nevi, you can see that the nevi are not white, they are not pale, they are more eosinophilic, but still they look quite bland. The nuclei doesn't show any atypia, there is no increased mitotic activity, and the cells grow in the small nests or islands. So this is a completely benign. Please don't be scared of those guys. Those are multinucleated melanocytes, and this is quite common in benign nevi. So this is not a sign of malignancy. So those floret-like cells, those multinucleated melanocytes, this is quite common, and it is not necessarily a sign of malignancy. So don't be worried by this. And last thing I wanted to mention is, as I said, one of the features that can help you to differentiate benign nevus from the melanoma is maturation of the tumor. You can appreciate it here. It is not striking. You will see better examples, but you can see it here at least a little bit. And if you look at the superficial portion of the tumor, you can see that it looks slightly different from the deeper portions. Those deeper portions are more pale. This is more dark. And it's because those melanocytes mature. And maybe you remember from embryology or histology that originally melanocytes are originally from neural crest. And as the benign nevus matures, those melanocytes start to resemble neural cells. So they will look less like melanocytes, and they will look more like Schwann cells, for example. So they will be smaller, they will be more pale, and they will be rather spindle-shaped. So here you can see that in the superficial portions, the melanocytes are more dark, and they are oval. But in deeper portions of the tumor, they are smaller, more pale, and more elongated. So they look more like neural cells. This is called maturation or neuroid transformation, and this is quite typical for benign nevi, especially for the bigger ones. And you won't see this in melanomas. So this maturation is a good sign. It's a good sign that helps you with the diagnosis. So let's abandon the compound intradermal and junctional nevus, and let's discuss something else. Well, I should also mention that it's good to know those subtypes, so we could recognize them, but from the clinical point of view, it's not so important, because there is no difference in biological behavior between those three subtypes. And now let's move to other type of the nevus, and this is a blue nevus. So let's discuss the blue nevus for a while. It is less common, but it is definitely not rare, and you will see it. The blue nevus, very often you can see it in children or adolescents, very often on the face, hands, feet, or buttocks. And why do we call it a blue nevus? It's because macroscopically, grossly, the nevus is blue. It's more bluish. It is not black or brown. So the blue nevus, it's basically a macroscopic descriptive term. It describes the gross color of the lesion. And why is it blue? It's blue because usually the tumor is situated much deeper in the dermis compared to other subtypes of the nevi. This is not the best example, to be honest, because in this example the lesion is situated quite superficially, but very often it's situated much deeper. And that's why the lesion is grossly blue and not black or brown. And how does it look like microscopically? There are several features that are quite typical for blue nevus. Well, first of all, it is still completely benign lesion, so you won't see any cytological atypia or increased mitotic activity. But the cells are not oval, as we could see in the most common nevi. They are not oval, but they are more elongated. They are rather spindle-shaped, as you can see here. So first of all, there is a difference in the shape of the cells. And in case of blue nevus, they are more elongated and they are spindle-shaped. And the second quite common and typical feature is this massive hyperpigmentation. Look how black it is. There is a massive deposition of melanin, and this is quite typical for blue nevus. Very often the pigmentation can be so dense that we don't see the cells anymore, and very often we need to use some special histological techniques how to get rid of the melanin. For example, we use hydrogen peroxide. So we need to depigment the slide, so we could see the cells that are hidden beneath the massive deposition of melanin. Because even melanoma can be so pigmented. So we need to be really sure that we are looking at a benign tumor. So very often we need to get rid of such a huge amount of melanin to really appreciate the shape and appearance of the cells. So this is how blue nevus looks like. Usually it's a deep-seated. The cells are more spindle-shaped, and very often it's highly pigmented lesion. Another subtype of the nevus that we should mention is so-called Spitz nevus. And the Spitz nevus is definitely good to keep in mind, because this can be very easily mistaken for melanoma, because the cells can be quite worrisome. Spitz nevus is a nevus that is typical for children and adolescents. And it can mimic melanoma. It can mimic melanoma histologically, as we will describe in a minute, and it can be worrisome even clinically, because very often it's a rapid growing lesion, so it can be worrisome on both clinical and pathological level. And how does it look like histologically? Well, first of all, sorry for the quality of the slide. The slide is a little bit shattered, but I think we will be able to appreciate the basic features. And here you can see the lesion. Here you can see the nests. And I think even at the first glance, we can see that this lesion looks more worrisome compared to the previous ones. And it is quite worrisome on the both cytological and architectonical level. Cytologically, the cells are typically there. Usually you can see combination of epithelioid and spindle-shaped cells. So those cells can be epithelioid, which means they are polygonal and they can look like epithelial cells. And some cells can be more elongated and spindle-shaped, but they are not so spindle-shaped as we could see in blue nevus, for example. But they are still a little bit elongated. So cytologically, there is a usually combination of elongated and epithelioid cells. But you can see that the cells are not exactly bland. They are larger, they are quite big, and there is some degree of nuclear irregularity. The nuclei vary in sizes and shapes. You can see small nucleoli as well. So this can worry you. This can be quite worrisome at the first glance. And also you can see that the nevus is not exactly bland on the histological level, as well on the architectonical level, because you can see that the nests are irregular as well. Some of them are large, some of them are smaller. Sometimes you can see irregular shapes of the nests, a little bit of fusion of the nests. So this lesion can be quite worrisome on both cytological and architectonical level. But still, the lesion is quite symmetric. That's the first thing that should help you. And second, as I said, usually you will see it in young patients. And as I mentioned before, you should always think twice before making a diagnosis of melanoma in children, adolescents, or young adults. If you saw this in older patients, you should be worried more, because it can be very easily a melanoma. There is also one special subtype of melanoma which is called Spitz melanoma or Spitzoid melanoma. But if you see this in a child, you should always think of a Spitz nevus. So as I said, Spitz nevus, it's a lesion that is typical for children and adolescents. The nevoid cells are usually spindle-shaped or oval or epithelioid, but they can be quite worrisome because they can vary in shapes and sizes, and also the nests are less irregular. They vary in shapes, sizes. Sometimes you can see a little bit of fusion of the nests, but still it's a benign lesion. So this was a Spitz nevus. So the last subtype of nevus that we will describe before we will move to melanoma is a dysplastic nevus. And dysplastic nevus is something we should definitely discuss, because dysplastic nevus harbors increased risk of malignant transformation. So this lesion, it is still benign. It is still considered benign tumor, but it can progress into melanoma in the course of the time. So we should definitely know it, and we should be able to recognize it. The lesion looks worrisome on both microscopical and macroscopical level. So even grossly, the lesion is usually larger compared to other types of nevus. It is slightly irregular. So sometimes there is some degree of clinical suspicion for that. And even histologically, you can see that the lesion is quite atypical. That's why we call it dysplastic nevus, because there is some degree of dysplasia. And you can see atypia on the both architectonical and cytological level. Still, the lesion is quite symmetric. So if you look at the lower magnification, the lesion is still quite symmetric. But when we go deeper, you can see that the lesion doesn't look nice. There are cytological atypia. The melanocytes in the nests, they are quite ugly looking. They vary in shapes and sizes, the nuclei are irregular, they are of different shapes, some of them are quite hyperchromatic. So the cells are not nice. So there is some degree of cytological atypia. Very often you can see increased mitotic activity. I cannot find any mitosis right now, but I think we would definitely find some. But you can definitely see some degree of cytological atypia. There is a variation in sizes and shapes of the nuclei. Some of the nuclei are hyperchromatic, so it definitely doesn't look nice. And second, you can see also architectonical atypia. You can see that some of the nests of the tumor are quite regular, but some of the nests are really irregular. They vary in shapes and sizes, and what is very typical for dysplastic nevus, and basically that's how you recognize it, is this fusion of the nests, this merging of the nests. So here you can see that the individual nests of the melanocytes tend to fuse, and they create some sort of bridges between rete-ridges. So this bridging and fusing of the nests of the melanocytes, this is highly typical for dysplastic nevus, and this will help you with the diagnosis, at least on undergraduate level of pathology. So dysplastic nevus, it's a nevus that is characterized by a degree of dysplasia, and you can see the dysplastic features on the both cytological and architectonical level. And remember this fusion of the nests of the melanocytes, which is typical feature for dysplastic nevus. Okay, and let's abandon nevi and let's discuss melanoma. We should definitely talk about it, because melanoma, that is something we all know, and we know that it's aggressive malignancy, and the overall prognosis is still not good. It is better than it used to be, because the new modern therapeutic approaches were introduced. We've got immunotherapy, for example, but still the overall prognosis is not good. It is usually situated in skin, so it's usually primary skin lesion, especially in sun-exposed areas, because the main risk factor is a long-term UV exposure. But you can also appreciate it in patients with immunodeficiency, and some of the cases can be familiar. And sometimes we can see primary melanoma even outside the skin, because you know that the skin is not the only site where you can find melanocytes. So you can have a primary melanoma of the mucosal surfaces, for example, especially in upper GI, oral cavity, esophagus. You can have a primary melanoma of the eye, because in the eye there is a lot of pigmented structures. Or you can have a melanoma of meninges. But still, these cases are not so common. If you have a case of melanoma that is not in the skin, that is in other region of our body, you should always rule out the metastasis. So if you have a mucosal melanoma, for example, you should always rule out the metastasis from the skin before you make a diagnosis of primary extracutaneous melanoma. The situations can be complicated by the fact that the skin melanoma can regress. So one of the features of the melanoma is the tendency to regress. So melanoma can regress, there can be a regression. So sometimes the metastasis can be the first clinical sign, it can be the first clinical manifestation. So, as I mentioned at the beginning of the lecture, there is plenty of subtypes of melanomas. Some of them are quite clear, some of them can be difficult to diagnose because they can very easily mimic benign lesion, they can very easily mimic nevus. We won't discuss all of them, definitely. We will discuss lentigo maligna, we will discuss superficial spreading melanoma, and nodular melanoma. And those three subtypes, they represent a spectrum. They represent a spectrum of progression. That's how melanoma progresses. So it starts as a lentigo maligna and then in progress to superficial spreading melanoma and nodular melanoma. Usually melanoma arises de novo. Less commonly, it's a progression from dysplastic nevus. Even less commonly, it can progress from other types of the nevus, or other types of the nevi, especially large congenital nevi. The congenital nevi can be really big, and in case of really large congenital nevus, it can be quite risky with regards to the melanoma transformation. But usually it's a de novo lesion or progression from dysplastic nevus. And as I said, it starts with lentigo simplex, and you can see it here. So this is lentigo simplex. Lentigo maligna. So this is lentigo maligna. And if you hear the term lentigo maligna, which tells you that there will probably be some resemblance to lentigo simplex. The both lesions are characterized by linear proliferation of melanocytes, which you can see here. But in contrast to lentigo simplex, in lentigo maligna, the melanocytes are atypical, and you can see it here. Look how ugly the melanocytes are. They vary in shapes and sizes. So even on the lower magnification, this is ugly looking lesion. But still, the melanocytes grow in a linear fashion. So they proliferate in a line, and they are situated in basal layer of the epidermis. So they are in situ. There is no invasion into the dermis. So lentigo maligna, this is basically a melanoma in situ. So you can appreciate the melanocytes in the basal layer of the epidermis with no invasion into dermis. So this is lentigo maligna. As I said, it can be mistaken for lentigo simplex, but in contrast to lentigo simplex, you can appreciate a striking atypia of the cells, as you can see it here. Quite commonly, it is not seen here, but quite commonly you can appreciate also the pagetoid spread. Remember, I mentioned it before, pagetoid spread means that the individual cells grow up to the superficial parts of the epidermis. So this is this is pagetoid spread, and this is another feature that is typical for melanoma, and you shouldn't see it in benign nevi. But the lesion is in situ. The lesion is in situ and there is no invasion into dermis. The next step will be the initial invasion. So in the next step you will see initial small invasion into the dermis, and such lesion will be called lentigo maligna melanoma. And as time passes, the invasion will be larger, but still quite shallow. So the lesion will be still quite shallow, and the dominant pattern of the growth will be horizontal. And such a lesion will be called superficial spreading melanoma, which we will discuss in a minute. And then as a last step, the dominant growth pattern will become vertical, and you will see a big and deep lesion, which will be called nodular melanoma, which we will describe at the end of the lecture. But here in this picture, we've got lentigo maligna. So this is the reason why you should be careful with the diagnosis of lentigo simplex in older patients in sun-exposed areas, because it can be mistaken for lentigo maligna, or lentigo maligna can be mistaken for lentigo simplex in those patients. What you can see here also are those changes in dermis. If you look into the dermis, you will see those numerous bands and fibers that are, let's say, blue or bluish or violet. So those violet bands and violet strands, these are degenerated elastic fibers. So these are degenerated elastic fibers. So there would be positive in stainings for elastic fibers, and this is the sign of cellular elastosis. So this is degeneration of the dermis, of the elastic component of the dermis, as a consequence of long-term UV exposure. And we call it solar elastosis. So this is the sign that this excision was excised from the sun-exposed area of the skin. So here you can see some solar changes. There is a solar elastosis, degeneration of the elastic fibers, and here you can see the lentigo maligna as a consequence of the long-term UV exposure. And the next step is superficial spreading melanoma. So in case of superficial spreading melanoma, there is a clear invasion into the dermis, but still the lesion is quite shallow, and the horizontal pattern of growth predominates here. So here you can see the lesion is still quite shallow, but it is not in situ, and there is also a dermal component. So this is superficial spreading melanoma. So here you can see there are irregular nests of atypical melanocytes with some degree of pigmentation. And what can you also see is this. As I mentioned before, this is pagetoid spread. So here you can see those individual pale melanocytes that grow and that infiltrate the epidermis, and they grow into the upper layers of the epidermis. This is pagetoid spread, and this is one of the typical features of melanoma, and you shouldn't see it in benign nevi. So this is another feature that tells us that this is not completely benign, but this will be rather melanoma. So this is pagetoid spread. What you can also see here is the inflammation. So those small black dots, those are not melanocytes, but those are lymphocytes and some plasmacytes. So there is an inflammation, and it is quite common. So melanomas are very commonly inflamed, and this inflammation can lead to the regression of the tumor, as I mentioned before. So the melanoma can regress, which is not always a good sign, because of this regression, the melanoma can be hidden to the naked eye, and the first clinical manifestation can be a metastasis. So here you can see also the inflammatory reaction that can lead to the regression of the tumor. And last but not least, nodular melanoma. So here you can see the lesion that is not exactly shallow. It's quite big lesion, and even at the low magnification, you can clearly see that this is something ugly. There is some nasty looking lesion. This is nodular melanoma. Very often it's eroded or ulcerated, and if I go to a higher magnification, you can clearly see this is a high-grade malignant lesion because it's hypercellular. There is a huge amount of the cells, and the cells are highly atypical. They vary in sizes and shapes. There are atypical or even bizarre looking nuclei with the prominent big and atypical nucleoli. And usually there is a brisk mitotic activity. I'm pretty sure we will find some mitosis sooner or later. So this is a clearly high-grade malignant tumor. So this is a nodular melanoma. What is quite typical for melanoma, and it can cause a lot of problems, especially in metastatic sites, is that the neoplastic cells are prone to substantial morphological variability. So the cells can be of basically almost any shape or size that you can imagine. And another problem can be a loss of melanin pigment. In this case, there is still quite a lot of melanin, as you can see it here, so there is no problem with the diagnosis. But quite commonly, especially the advanced melanomas, can lose the capacity to produce the melanin because the cells are immature. So sometimes the melanoma can be completely devoid of any melanin pigment, and this can be problematic, especially in metastatic sites, because as I mentioned, the melanoma cells can be very variable with regards to their appearance, and very commonly they can lose the capacity to produce the pigment. So especially in metastatic sites, it can be very complicated to recognize this tumor as a melanoma. So as the unwritten law for pathologists, If you see a malignant lesion somewhere in our body and you don't know what it is, always consider melanoma. Always rule out the melanoma, despite the morphology. But here in this case, we've got no problem because we've got atypical cells, but they still look like melanocytes, and there is a huge amount of melanin pigment. And also remember that I mentioned that in case of benign nevi, if the benign nevus is bigger, it tends to mature. It tends to mature, and the deeper portions of the benign nevus look different from the superficial ones because there is a maturation of the cells. But you don't see it in melanoma, and here you can see that even the deeper portions of the tumor look basically the same as the superficial ones. So there is no maturation of the cells, and that's another typical feature of melanoma. So there is no maturation. Okay, so that's basically all. I think we discussed all the most important subtypes of nevi and melanomas that you should know on the pre-graduate level of pathology. So thank you for the attention and see you soon. Bye bye.